Okay, welcome everybody. My name is Jeff Kwong. I'm the interim director of the University of Toronto's Center for Vaccine Preventable Diseases. And I have the pleasure today to be moderating a session, a webinar on defining COVID-19 vaccination priority groups. We've got 3 excellent panelists today. And this webinar is actually a joint webinar between the Center for Am I still on? For vaccine preventable diseases with the Joint Center for Bioethics. And this is part of the JCB's Bioethics Seminar Series. So before we start, I'd like to make an acknowledgement, the Indigenous Land Acknowledgement. We would like to acknowledge the traditional territories of the Mississauga of the New Credit First Nation, Anishinaabe, Wendat, Huron, and Haudenosaunee Indigenous peoples on which the Dalla Lana School of Public Health now stands. The territory was a subject of the Dish with One Spoon Wampum Belt Covenant, an agreement between the Iroquois Confederacy and Confederacy of the Ojibwa and allied nations to peaceably share and care for the resources around the Great Lakes. We would also like to pay our respects to all our ancestors and to our present elders. So a few housekeeping items before I introduce the panelists. We will try to address as many questions as possible, but the time is limited, so we probably won't be able to get to all of them. If you do have questions, direct them to the panelists in the chat box. And then if you have any questions afterwards, after the webinar, you can also send them to the email address cvpd.dlsph@utoronto.ca, and you'll see that as well. Okay, so now I'd like to introduce our panelists. First of all, we have Dr. Matthew Tunis. Dr. Tunis is the Executive Secretary to the National Advisory Committee on Immunization, or NACI, at the Public Health Agency of Canada. He is also an adjunct professor at the School of Epidemiology and Public Health and the Faculty of Medicine at the University of Ottawa. His research focuses on vaccine policy and research, public health policy, knowledge synthesis, guideline development, knowledge translation, and immunology. Second, we have Dr. Maxwell Smith, who is an assistant professor in the Faculty of Health Sciences at Western University, where he co-directs the Health, Ethics, Law, and Policy, or HELP Lab. Dr. Smith is a member of Ontario's COVID-19 Bioethics Table and the World Health Organization's Ethics and COVID-19 Working Group. His research focuses on the ethical underpinnings of the pursuit of health equity and social justice in public health, with a particular focus in the area of pandemic preparedness and response. And last but not least, we have Caroline Lidstone-Jones. Caroline is a Ojibwe and a member of Batchewana First Nation, and her roots stem in Northern Ontario. She is the Chief Executive Officer of the Indigenous Primary Health Care Council and is formerly the Chief Quality Officer at Winnebago Area Health Authority, located in James and Hudson Bay, and is former Director of the Aboriginal Cancer Care Unit of Cancer Care Ontario. So please join me in welcoming our 3 panelists. And the format is we'll have each of our 3 panelists present for a few minutes, and then we'll have some questions to our panelists. And we'll also have some questions from the audience as well at that point. So without further ado, we'll go to Matthew Tunis. And we'll get our slides up. Perfect. Okay, Matthew, over to you.
Thanks, Jeff, so much for the introduction. And yeah, thanks for the opportunity to be here today. Really excited to have the discussion with the panelists here. So I'm going to go through a brief presentation. I'll try not to spend too much time on it. I know the focus is really on discussion and answering questions, but I'll set the stage a little bit. So as Jeff mentioned, I'm the Executive Secretary to our National Advisory Committee on Immunization, or NACI, here in Canada. That's an external advisory body to the Government of Canada. So I work for the Public Health Agency, and I'm the bridge between the government and this expert body who's been issuing recommendations on vaccine prioritization, and then they will also issue recommendations on the individual vaccines once those arrive. Next slide, please. So NACI's work is really being focused under two phases. So there's preliminary guidance that is due to be published actually next week, and that's before a vaccine candidate has been identified. So their preliminary guidance will be vaccine agnostic, and that's due very soon. And to generate that, the committee has reviewed available evidence on the epidemiology and burden of COVID-19 to issue that preliminary guidance about really a menu of which groups seem to be obviously at risk and key priorities for early immunization. But that group can't really, they can't be sequenced and they can't be ranked. There are too many unknowns still about the evidence landscape. For example, the clinical effectiveness and safety of the vaccines is unknown, and also the dose delivery and schedule. The quantities of doses and the schedule are still unknown as well, which makes it really difficult at this point to do actual prioritization and sequencing. So really the committee is focused on establishing key populations. And then there will be ongoing guidance as we move through time and more data accumulate and vaccines actually become authorized in this country. Then the committee will get down to the work of actually sequencing among those key populations, which ones would be optimally targeted for the earliest doses of that vaccine. And then as the program rolls out, there would be future updates. So that's work to come. Next slide, please. This slide shows a brief overview of the evidence base that NACI takes into consideration when making its recommendations, either on vaccines specifically or on prioritization. So down the left-hand side, you've got the burden of disease, which is always very central. Then the vaccine characteristics, so the efficacy, effectiveness, immunogenicity, and safety, all of which are currently unknown about COVID-19 vaccines. And then ethics at the bottom is a core filter that overlays all of their work. And down the right-hand side of this spectrum, you've got acceptability, feasibility, economics, and equity. Economics, we don't really see a role for early on in these emergency use scenarios of pandemic vaccine. And as people are aware, the government of Canada has already made commitments to procure many millions of doses of vaccines. So those decisions have already been taken. I think economic analysis would likely be integrated by the committee more into the future if there's consideration for a routine program. That's where those questions might come up. But those other elements are absolutely central to their decision making now, including the prioritization advice. And equity is very central to this. We know that health equity is really at the core of a lot of the COVID-19 pandemic discrepant impacts. And so the committee is very attuned to that, has been looking at those data. Next slide, please. This is an overview of a survey that was conducted over the summer to support the committee's decision-making. So as the public health agency, we provide secretariat support to NACI to try and collect evidence so that they can make their expert decisions. And we did go out and survey a number of stakeholder bodies, including most of the health professional associations in Canada that have any relationship to immunization, also provinces and territories, and a number of key national Indigenous organizations to understand basic values and preferences around prioritizing pandemic vaccine in the case of COVID. If you look back to H1N1, there's actually very little literature about expert values about prioritization of immunization strategies. And we know how it was rolled out, but there's not a lot of documentation about the rationale and justification for that. So we were trying to enable a more evidence-based or evidence-informed process this time around, and went out surveying that group of experts on which immunization strategies they would see as being highest priority to support the pandemic public health response goals. So you can look at protecting those who are most vulnerable to severe illness and death. You could look at minimizing transmission of COVID disease and transmitting to those who are at severe, at vulnerable outcomes of severe illness and death. And then also protecting critical infrastructure and protecting healthcare capacity. Those seem to be major streams or strategies that would be for consideration. And on the next slide, you'll see some results from that survey. And these data did help inform the committee. I mean, it's certainly not the only input that the committee was taking on board, but sorry, if you can just progress to the next slide, we'll get a quick view of the, so these are the organizations that were surveyed. And on to the next, please. Yeah, so here you see, really interestingly, across the board, the values and preferences from those health professional organizations, really the public health expert bodies in Canada, were all focused on protecting those who are most vulnerable to severe illness and death from COVID-19. And the different scenarios here, I'm not going to go through them in detail, but we did ask through the survey to rank the different strategies depending on different epidemic scenarios, right? So if you're in the middle of an overwhelming wave, then you might be more concerned about maintaining critical infrastructure, some of those other things. Whereas if COVID-19 is in a low-level endemic state, then we had assumed that the values and preferences might actually be quite different. But you see here that they're really conserved, the order across the board. And so across all those scenarios, protecting those who are most vulnerable to severe illness and death was really at the top of the list. Now, that's not to say that healthcare workers and other groups that are not necessarily at highest risk of severe illness and death, not to say that they wouldn't be considered for early prioritization of vaccine. I mean, that could be a really meaningful intervention to actually try and achieve that goal of protecting those who are vulnerable to severe illness and death. And then there also are, of course, logistic considerations that come into play around the volume of doses. And when you think about equity, if, for example, you were seeking to immunize everybody 70 plus, that's many millions of Canadians. And if there aren't many millions of doses out of the gate, then it might actually be more feasible to try and achieve a smaller cohort, something like healthcare workers. So, this just ties into all of the unknowns, but NACI's been trying to really set the stage with a menu of options of what the immunization strategies might look like. Next slide, please. Here's just an overview of the equity matrix that the committee has been using to inform their deliberations. And this is published in preprint right now. And it would be included as well in the full guideline that the committee should be publishing next week. So you see, it's based on the Progress Plus tool. So it's an organized, systematic way to ensure that the committee is thinking through all the social determinants of health when deliberating on their recommendations. So things like pre-existing condition, place of residence, race, ethnicity, occupation, gender, sex, religion, education level, social capital, age, and other factors. So those are all being explicitly considered by NACI, and they've been thinking through why inequities may exist and then examples of interventions that could reduce the inequity and improve access. Next slide, please. And just to highlight at the end here that there are also ethical filters and core ethical dimensions that NACI is using to overlay on their recommendations. Next slide, please. These will also be included in that publication next week, but just to highlight here, some of the themes, the ethical themes of justice and distributive justice, and are the recommendations equitable in terms of accessibility, and then also considering feasibility, are immunization programs feasible in different settings? That ties into, of course, equity and place of residence. Things like remote and isolated communities have unique feasibility barriers. So NACI has these two matrices that they've been using to work through these issues, the equity matrix and also a feasibility matrix. And on the next slide, and this is just about my final one. So there you have some ethical procedural considerations. And next, please. Very interested to hear Maxwell's thoughts. I know that as a philosopher and ethicist, he'll have some opinions, I'm sure, but inclusiveness, of course, as well, were relevant stakeholders engaged. So the survey was one mechanism by which to engage some stakeholders. And after NACI's preliminary guidance is published, we are working with researchers to do public opinion research to actually try and ascertain public acceptability and values and preferences around the different key populations that NACI will be identifying. And then that can feed back into NACI's final recommendations to understand how the public will perceive prioritization of different groups. And next slide, please. So there's just an overview of the NACI High Consequence Infectious Disease Working Group, who's been developing the preliminary guidance. Then that's fed up to the full committee, and that will be published very soon. So that's the end of my my presentation. Thanks.
Great, thank you so much, Matthew. Next we have up Max. Are you all set with your slides? Great.
I am, if you can see them. Yeah, thanks very much, Jeff, for the introduction and for the invitation to be part of this panel, and for the privilege to be able to speak along with Matthew and Caroline. So I hope to do two things with my remarks. First, I hope to argue that ethics isn't just one of the, or one consideration among many considerations when defining priority groups, but rather that ethics should actually serve as the foundation upon which priority groups are identified. And the second thing that I want to do is to synthesize some of the main ethical principles and priority groups that have been proposed thus far in the COVID-19 ethics literature or by other countries' allocation frameworks, which I'll note at the outset tend to come from Western and English-speaking countries and authors. So to begin, we can assume that a shortage of vaccines will mean that difficult decisions will have to be made about who should receive the vaccine first, as well as the priorities for subsequent vaccine rollout. Decisions about how these priorities should be set reflect choices ultimately among competing values, or in other words, choices about the objective or objectives that society values realizing or achieving the most through a vaccination strategy. Evidence alone can't tell us which choice is ultimately legitimate or justified. This requires a value judgment of some sort, which inherently raises questions of ethics and specifically questions, as Matthew said, of distributive justice. And so the central questions, I think, are which value or values should form the ethical foundation upon which priority groups are identified, and whose values count. So these questions and the responses we might provide in response to them sort of contrast with the way that many approach the question of prioritization. So I think many will jump right to the question of who are the priority groups. And proceeding in this way would not really be a principled way of identifying those groups. A better strategy, albeit one that is still limited, is to ask what the evidence says in terms of which groups are perhaps most affected by COVID or would most benefit from being vaccinated. But proceeding in this way involves making an implicit value judgment and presumption about what should be valued the most in our vaccination strategy. So I think first and foremost, these underlying value judgments need to be made explicit. So consequently, priority groups should be informed by allocative criteria, which should be informed by the programmatic goals of the vaccine strategy, which should themselves be informed by foundational ethical values and principles, where each step is informed by ethics and evidence. So what are those ethical values and principles that the ethics literature tends to propose to serve as this foundation? The principles that you can see on the screen here are those that are most often proposed in the literature, with the ones on top being the most common and the ones in parentheses being less commonly proposed, but still in the literature. So the three, all of the principles really have lots of different interpretations, but I'll just quickly speak to each of them. The principle of maximizing benefits and minimizing harms reflects the ethical obligation to protect and promote the public's health and the socioeconomic conditions that are instrumental in doing so. The principle of equal moral concern and respect requires that every person is treated as having equal dignity, worth, and value, which I think we can view as being supportive of human rights, various human rights and conditions. The principle of justice, as Matthew alluded to, requires that we meaningfully acknowledge that COVID and even the measures that we adopt to combat COVID have a disproportionate impact on populations who are disadvantaged by virtue of their race, their ethnicity, their age, their health status, their residence, occupation, and socioeconomic status. And so justice requires explicitly addressing the higher burden of COVID experienced by these populations, and then working actively to prevent and mitigate those disproportionate impacts. It's also critical that the process by which allocation decisions are made are ethical and fair. And this can be accomplished by ensuring that the processes, the decisions, and the reasons themselves that underlie those decisions are made transparent, and that those impacted by decisions, which is pretty much everyone in Canada, have input into decision-making, into the process, and are included in decision-making itself. So the identification of foundational ethical values and principles should then inform the goal or goals of the vaccination strategy. And again, because the goal reflects a choice among competing values, this is why the ethical foundations are very critical. As you can see in the bottom right of your screen, Jane Williams and Angus Dawson published a nice review paper earlier this year, which reports the most common programmatic goals proposed in the ethics literature in the area of pandemic influenza vaccination. And so you can see here, there's multiple different programmatic goals that are often discussed, including saving the most lives possible, reducing the spread of infection, protecting the worst off, reducing economic and social deprivation. Some of these were listed in some of Matthew's slides. It's also important to note that the ethical values and principles we consider to be important might lead to one goal, or it might lead to actually multiple goals, and that the goal of a vaccination program is likely to evolve in relation to the characteristics of the pandemic, perhaps the severity of the pandemic, as well as the rollout of the vaccine itself. So next we need to ask which allocative criteria and indicators have the greatest fidelity to those ethical principles and values and are capable of operationalizing the programmatic goals. And here you can see that there's lots of different allocative criteria that we might choose from. Here's a couple that would ostensibly promote what we would consider to be formal equality. So this would be a first come, first served sort of allocation or a lottery. There's many that would aim to maximize best outcomes, including prioritizing those with the greatest risk of dying if infected, most likely to recover if infected, prioritizing the youngest, and so on. Several allocative criteria that would ostensibly aim to prioritize the worst off, including prioritizing those most susceptible to infection, most likely to be infected, those that are at greatest risk of dying infected, and so on. And then also allocative criteria that would prioritize those that are tasked with helping others, like prioritizing essential workers. So as you can see, the same allocative criteria might actually be used to operationalize different programmatic goals. And then finally, once we've identified foundational ethical values and principles, the programmatic goals that are supported by those values and principles, and the allocative criteria and indicators that would operationalize those values, principles, and goals, they'll provide a principled way to tell us which group should receive greater or lesser priority. In the literature, priority groups are commonly categorized in terms of occupation, in terms of medical vulnerability or social vulnerability, stage of life, and social clusters. And the priority groups most often proposed in the ethics literature for the emerging COVID-19 ethics literature, as well as the pandemic influenza literature, are high-risk healthcare workers, vulnerable populations, even though that term is often used as a catch-all and fails to really identify what that means, as well as older adults and children. And just as an example, the US National Academies of Sciences, Engineering, and Medicine have produced their equitable framework for vaccine allocation. And you can see here at the bottom, they've started, just like I've said, with foundational ethical principles. They've included maximum benefit, equal concern, and mitigation of health inequities, as well as procedural principles, including fairness, transparency, and evidence-based. These support and inform the overarching goal, which is to reduce severe morbidity and mortality and negative societal impact due to the transmission of the virus. Those in turn lead to allocation criteria, which they've included risk of acquiring infection, severe morbidity and mortality, negative societal impact, and transmitting infection to others. And then they've actually included different priority groups depending on different allocation phases. Early phases emphasize the prevention of severe morbidity and mortality, which translate to the prioritization of high-risk healthcare workers, first responders, those with high-risk comorbid and underlying conditions, and older adults living in congregate living settings. And later phases focus on reducing transmission, which translate to the prioritization of homeless populations, people in prison, teachers, children, among others. And so I'll just end with some general ethical considerations that don't speak exactly to what I've mentioned so far, and perhaps these can serve as discussion points. I'm wondering whether what would the arguments for prioritizing different groups look like, considering when we consider access to other preventative and therapeutic measures. So are we taking that into account when we're identifying priority groups? I wonder, should those most burdened by restrictive measures like isolation, so if we're asking older adults to isolate longer or more than others, should they receive greater priority for vaccines? I think we should also ask what's owed to those who don't receive priority. Do we have other reciprocal obligations to those that won't receive the vaccine right away? If proof of vaccination will be required for school, for work, or for working with vulnerable populations, say in long-term care homes, or for travel, how should that be reflected in vaccine priorities? And finally, because populations who may be placed at the front of the queue are less likely to have been included in vaccine trials, despite the good work of NACI trying to promote these groups being involved in vaccine trials, what post-market surveillance strategies will be used to protect them from harm? So I'll stop it there. Thanks very much for your attention.
Great. Thanks, Max. And then next we have Caroline. And get our slides perfect. Okay, Caroline.
Perfect. Thank you. Thanks, everyone. I'm very pleased to be here as well. I just wanted to share right up front that I'll be talking about my slides from a community perspective, and in particular, the impacts on the Indigenous population. And I think also to set the stage on how we look at ethics as a social science and how we work with that within our systems, but then most importantly, what is the impact on real people? And that is essentially what we're talking about. So I wanted to share some of the examples that we've learned and also impress upon people who are in the healthcare sector to think about some vital questions, similar to what my co-panelists had talked about when working with populations and working with people. So next slide, please. So just to set the stage, why is it important for us to consider the Indigenous perspective? And what have we learned from the current COVID experience? And I think it's an important stage setting example of things that we've learned and how do we apply that learning in the way we approach doing healthcare in communities. So I really hope to also translate for people when we're dealing with ethics, there's true impacts to communities and what level of impact do we have on those communities to bring the realness to the situation. So next slide, please. So I want to talk about what we learned in the COVID response in our First Nation communities. So a lot of the data, so when we talk about what data accessibility and research studies individuals have access to, I'll pose a series of questions at the end of this talk to challenge you on how we look at validating data and how we look at validating knowledge. And there's certain ways in our communities that extend beyond your traditional philosophies of how we would look at validating our knowledge systems. So I just wanted to share from this perspective, if you were to look at the current data, our actual First Nations communities in the on-reserve setting, as which people define them as, actually have fared fairly well in the COVID response. And but how have they did it, and at what cost? So just to give everybody a perspective, in Ontario, so I work with Indigenous Primary Healthcare Council members in Ontario. In Ontario, the response of First Nations communities were actually to close their borders and not allow individuals who were not from that community in or out. So what that meant was they contained what was in their community right off the bat without allowing any outside influence to come into the community. But we're certainly seeing a massive cost to that with our communities. So as community partners, examples, those living in Indigenous or in urban settings in the Indigenous populations actually had to respond to our communities by dropping food off at their points of entry into their communities. They had to take on a policing role of which was quite a difficult task and feat. They also had to deal with issues around it not being effectively resourced in their communities and being able to keep at bay because once they knew if COVID was getting in their actual community borders, the cost could be detrimental. And I think that what's important to understand when you're talking about the ethical principles of that, and this doesn't tend to come into a lot of conversations that we see in, I think, mainstream academics and how we approach looking at ethics. But one of the foundational principles that communities, in particular for First Nations, Métis, and Inuit, we're struggling to do cultural revitalization. So a lot of, when you're talking about communities having to respond to cultural genocide and trying to revitalize a culture that has been lost with many years of decimation, you could have very real examples where if COVID enters your community boundaries, you could be having the last remaining speaker of your native language dying with that individual, or those who would have traditional ceremonies that you practice for years and have not had people who are actually trained to carry that knowledge forward. Traditional medicines and traditional practitioners who have worked in our communities, who have been performing traditional teachings and doing those cultural revitalization aspects to the community, actually be the hardest hit in what we call the vulnerable population. So, you know, it's really important, I think, when we're rolling out strategies and we're taking a look at this, these are very real ethical issues that Indigenous communities would struggle with around looking at things like prioritization. We just went through an exercise of how to do clinical triage if you had come to a state where all of our hospital system wasn't able to respond, and you had to select and choose who was going to get service or who wasn't. So when you're talking about some of the selection criteria that you're using, you have communities and individuals who have multiple comorbidities. You have individuals who are our knowledge keeper in our communities who might very well be part of the haves and the have-nots around being decided upon to receive this vital care. So those are some types of things that really concern us from a community perspective. But we also had some sacred wins, I think, from the COVID response. So we had some gifts that I don't think, despite the pandemic being very challenging, we also were able to band together when PPE became a vital state for the world on a world stage. Our communities banded together and actually formed their own PPE supply chain, and we're able to get critical supplies in our communities to maintain primary care and maintain care systems in place so we could keep people out of the hospital. We had to rely on each other as community support people that extended beyond the boundaries of healthcare. And I think when we were looking at, my co-presenters talking about the social determinants, this was the social determinants at work. This was the social determinants at play. And how we had to work together as a community to address this. Next slide, please. Now, the COVID response in the urban setting has been quite different. So, and I don't think what a lot of people realize, we actually have 86% of Indigenous peoples in Ontario living in urban settings. And so some of the things that we saw in our COVID challenges were not restricted by boundaries in the urban populations. So one of the things we saw early on in the COVID response was a lack of support for testing. So they were doing testing and assessment sites. It was something right off the bat that our sites in primary care said, absolutely, we'll enter into doing testing and assessment for our community sites. Please just give us the appropriate resources like the tools, the PPE and things like that that are required, and our nurses and doctors will absolutely respond and deliver this response. What we had heard was actually in some cases, some of the regions in Ontario were actually choosing to potentially shut down testing and assessment centers in some locations that we were begging to have a site in. And what we had heard from it was, oh, well, actually, we're not seeing as many uptake. We're not seeing as many individuals going in for testing and assessment in that location. So we're just going to shut it down. But the reality was it was in locations where your hardest hit populations were not located. So those were populations that did not feel comfortable to go into those other communities that they did not typically get service in to go for testing and assessment. So even around the ethics of where do you select site location for things like testing and assessment, an ethical principle, an equity principle comes into play around those kinds of things. The other thing that comes into play, there's actually no race-based data that's available through our data collection systems to identify people who are First Nations, Métis, Inuit. We have some of it beginning to happen through some public health units with our COVID response, but it's not a standardized response. It's not a system. So when you talk about digital and data equity, this is not things that we can truly talk about when we talk about access to data. So, so when we're using the most available data, what we tend to forget in those conversations is some of the most vulnerable's data is not even available because it's not studied or systems are not in place to be able to capture that type of information. The other thing I think that came into play in us taking a look at our COVID response in general is taking a look at things like your stigma and messaging. One of the things that is extremely important around the public health messaging is to give consistent messaging at the community level. Another thing that's hugely important to understand for the Indigenous population, there's two jurisdictions. There's a federal jurisdiction and there's a provincial jurisdiction. Many times those jurisdictions do not talk to each other. So we're operating what you typically would feel through your public health response through a provincial-based system. For Indigenous people on reserve, it is actually under a federal mandate. When those two systems do not talk to each other, that causes inconsistency in messaging going out to communities. So no matter how efficient we might be in trying to put out key messaging to the group and to do equitable just distribution of resources, if we do not look at those system challenges, that causes a whole other set of challenges around doing prioritization, also us taking a look at any of those system barriers that may be in place that we never even considered as part of our strategy in how we do allocation processes, how we take a look at doing any of the strategies that we're looking to move forward. So when it comes to, I think there's no great mystery, the evidence and the data we do have access to, mental health and addictions has just surpassed any of our concerns of what we're feeling in the COVID response right now. And we're struggling right now as communities to even stabilize how we would look at doing traditional ceremonies and medicines. That's a very, very community-based activity. There is a lot of community connectiveness in that. And so when you're talking social distancing and all of those kinds of things, this is a further burden on how we respond just in generally. I think with us dealing with prior trauma, adding on now a pandemic where now we're asking people to forcibly be in confinement and maintain distancing adds a further level of complexity to the current realities that many of our communities and populations are facing. But most importantly, I want to share the successes. We actually had mobile testing units that opened up. We actually saw testing go in a mobile unit to the most vulnerable hit populations in larger urban settings like Toronto and Ottawa. We took the testing to individuals, not expecting that the individual would respond to the testing. Another small example I will give you, with the recent announcement of the province in Ontario doing the expansion of their testing and assessment site, they chose to expand testing and assessment in pharmacies. Can I press upon people to think about how would a homeless individual who may have to go in for testing feel comfortable going into a pharmacy to receive testing and assessment over a community-based organization that was designed to work with them and go to the most vulnerable populations in the province? And those are things I think when you're talking about equity and you're talking about ethics and you're talking about vulnerabilities and you're talking about, you know, and as Maxwell so elegantly defined, how do we define what vulnerable even means? That's examples, that's true community examples of how these actual actions that we translate to the community level, this is how it impacts our communities. The other thing is, in the beginning, we were actually not invited to critical tables where decisions were being made. We actually had to advocate to the ministry to be involved in the collaboration tables that were happening across the province. And there were 5 of them. So we had to advocate hard to get representation. So any of that Indigenous voice, whether it be First Nations, Métis, or Inuit, had a voice at the table. So in making those decisions, you need to carve out spaces where those vulnerable voices have a voice and they have some power in that system to share whatever it is those strategies are moving forward. They know their communities best. And I think that that also has to be a principle that we start interjecting in any of the strategies that we do. As I mentioned, we got to know the Chinese market way more than anybody on how to actually secure PPE. That became something that we never thought we had to do as a sector, but to ensure accessibility and to ensure that our doors remained open during the pandemic, we did what we had to do. So I just wanted to share some of those examples. Next slide, please. And you're probably wondering, what does this have to do with ethics? And what does it have to do with us taking a look at a vaccine? So essentially what I wanted to do was set the stage of, we're having this conversation because of COVID and the COVID response. Our systems teach us lessons as we go along the way. And I wanted to share some of those things that we've actually learned in hopes that those people that are in positions that actually have influence in our systems will think beyond their four walls of what they're academically trained to look at, or things of how we impress upon taking a look at it from a very macro system perspective to what does it really mean at the community level? And what does it mean when it impacts us as people at the community level? So that's what I hope to do with this talk. Next slide, please. And how do we take a look at doing this? So I actually got this off a Canadian Treasury Board website. How did they define ethics? They talked about it as ways of living concerned with human conduct, how we give justifications for moral judgments. How do we look at what's morally right and morally wrong? How do we look at basically our human behavior and what does that mean to our positioning in our natural environment? And how do we conduct with each other as humans to humans? Just to share with you some of the Indigenous worldview and how decisions have been made and how we've moved forward with some of this pandemic response. We definitely had to create safe spaces to share our experiences. And we had to be able to do that in a way that we could engage in discussions that were difficult. Because when you're making decisions and when you're looking at ethics, we need to realize that ethics impact people and individuals, and you're not alone in the system to make those decisions. And that's a very important thing, I think, as a community member to say to you, that collectively, we need to be looking at what our collective responsibility is into this. How do we do things like sharing power, our active listening? How do we brainstorm solutions? And we do that in a collaborative fashion. And how do we ensure collective accountability to our system? So you'll look at things that are quite separate in how we look at that as a philosophy and how we look at it as a worldview and how we actually live and work in a system. So next slide, please. So how do we make an informed decision? One of the things I want to share is just because we're saying in the mainstream or saying in our larger system that, yes, we're going to view the Indigenous population so that we're looking at it with regards to how to do a vaccine. I wanted to share just from our historical context, just because you prioritize the Indigenous population does not mean that people will be accepting of the vaccination. And that ties to our historical context of how we take a look at ensuring right now, historically, we actually had Indigenous people be guinea pigs for certain medical tests, for certain things. An example is the smallpox and how it materialized and morphed in our communities and created mass decimation. So just because we make it available does not mean people will be accepting of it. So I just wanted to share that as well as an example. And then our next slides are the series of questions. I know I'm going way over my time and I won't read these, but these are things that I hope can share out to your group after when you look at things like who's validating your research, what research are you having, whose data, how are we collecting data for the most vulnerable? Next slide, please. how do we look at things like ensuring that we actually have data frameworks so we can actually work with the most vulnerable populations and validate their voices? Is it ethical for us to assume that we're asking them to prove that they need this support when we have not given them the systems to prove that, as like our mainstream systems, our very westernized systems do? And I think the final question, and there's other questions beyond this, but what has really pushed our limits to look at ethics. Now, what about in the face of a world pandemic where all countries are sprinting to help limit the spread and death? Our most vulnerable are the hardest hit, and we know this by the current data. Does this mean now that we're making others vulnerable? How do we act and behave in this circumstance? So in other words, we now are all vulnerable in this state, and we don't have the appropriate tools where we're our most vulnerable who are hit to be able to actually combat this in an equitable way. So the other questions I won't go over, but I really hope it just impresses upon you to think about this situation and how it impacts the community level just from a different perspective. Thank you.
Great, thanks so much, Caroline. Now we have a few questions for our panelists, and please feel free to ask your questions, and you can put them into the chat. So first, for Matthew, what particular challenges do decision makers face when defining vaccine priority groups within the context of a pandemic?
Yeah, I mean, I think the first challenge that obviously comes to mind is data, right, and data availability. And as things are moving so fast and the data are still emerging, we saw that with NACI and the committee, that there are a number of data gaps. And so the NACI had actually put out research priorities early on, like in July, I think, to try and identify what areas of research they would ideally see data coming out on to help inform their prioritization recommendations and the eventual vaccine recommendations. I mean, things like the certainty of evidence associating high-risk medical conditions to COVID severe outcomes is still really unclear. So we'd conducted a systematic review with colleagues at University of Alberta to try and inform NACI's decision-making on that. But as you'll see once the guideline is published, the quality of evidence is not very high, because early in the pandemic, studies weren't necessarily well adjusted for confounders like age as being one of the most obvious, where we've seen age being such a dominant risk factor, but that's obviously confounding with some other medical conditions. So really nailing down some of the data on exactly who is even at risk for severe outcomes has been a big challenge. And then as I mentioned before as well, and I think it kind of touches on what some of the other panelists were describing, understanding Canadian values and preferences around prioritization, because it's fundamentally it's a priority driven exercise, and it's a values driven exercise. And so understanding what are those ethical values that are really dominating the Canadian landscape. There are many different ways that you could seek to prioritize vaccine depending on what you're trying to achieve. And so that's also been a challenge. We've done a bit of work to try and ascertain that. And as I mentioned, we'll do a bit more public opinion research, and the preliminary guidance should help provide a sounding board to then be able to understand how people react and respond to that, to then iterate on it. But really it's the lack of data, really, and the data availability has been a real challenge from my perspective. And I think the committee would probably echo that.
Mm-hmm. Thank you, Matthew. Now a question for Maxwell. This is, kind of maybe if you can answer to one of the questions you posed. What, if anything, is owed to those who are not prioritized for COVID-19 vaccination?
Yeah, I think it's an important question, because it's one of the only questions that asks us to think about how vaccine prioritization actually is situated within the broader response, right? So actually just answering the question of who should be prioritized doesn't really tell us much about anything else that's going on in the pandemic response or generally in our healthcare system. So I think that, it's important to appreciate that whoever we prioritize first out of the gate doesn't just mean that people like me who happen to be relatively well off won't be prioritized. It means that even people that are moderately are at moderate risk of infection or disease won't be prioritized. And we really need to make sure that if they're not getting the vaccine right out of the gate, that we really need to ensure that we then have other sorts of supports that will either prevent them from getting ill or treat them when they get sick. So I think, we need to look carefully not only at who we're prioritizing, but who we're not. And then we need to invest further in supporting those communities that are further down on the list.
Okay, thanks, Maxwell. And for Caroline, what role can individuals, communities, and advocacy groups have in influencing dialogue on vaccine prioritization processes?
I think one of the main things that I would say in that is making sure that there's an open space to have the dialogue, and making sure that there's recognition that, and I think this is again pressing upon what Matthew and Maxwell had shared, saying, just because we have a Canadian value system that we view as values does not mean everybody shares that value system. So I think what's important is how we define, I think even utilizing the term vulnerable makes a different classification of vulnerable. So I think that when we're talking about having to have individuals and people in place, we need to make sure there's that space where they're actually invited to the table to have that level of discussion. And they're not having to fight to get to that table to have that level of discussion, because they can bring very real examples. And that's why I was hoping to bring very real examples of how this current COVID pandemic, because as Maxwell said, if we're talking prioritization, you're going to have people who have it and don't, which means if we don't have stabilization in our other parts of the system, and those parts aren't equitable either, then really we haven't solved our issues just generally across the board. So I would say that whoever's in decisions of authority and whoever are also working with individual populations, make sure that you fight to have a voice at the table, and make sure that you have recognition in your voice, to say that you deserve to have a voice at that table.
Okay, thanks, Caroline. So we have actually no questions from the audience yet. We have 3 comments, which I'll read out for the audience. So first from Rebeccaschlansky. Hi, Rebecca. The vaccine characteristics will also influence priority populations. For example, they may be less effective in older populations, and just in general, how effective it is. Second, from Red Bioethics, colonialism must be included in the list of health inequities. Understanding how colonialism impacts the social determinants of health can inform ethical principles such as reciprocity and stewardship. And then from Beth Thies, hoping NACI won't be too swayed by public opinion, but by the kind of reflection that Maxwell and Caroline have presented here. And here is a question for Caroline from Sigan Ogadeli. A new way of implementing ideas is needed. What is being done differently to improve acceptance amongst Indigenous groups?
So acceptance as in the sense of what's happening currently in the, I'm not sure if I fully get the question.
Yeah, I'm not. I mean, I think it's, acceptance of the interventions that are being done, or like
Okay.
Vaccine and.
Right.
Could I give a little preface to that question?
Sure.
Something that, and maybe we'll take it off in a direction other than what was intended, but I guess that's the panelist prerogative. So in NACI's workup to develop their advice, there has been some public opinion research, and the point was well made actually before. Public opinion is not the end of a conversation. Absolutely, it's one of the inputs, right? That I demonstrated in that figure. That acceptability is one of the many inputs, including other scientific factors, and that NACI considers. But so far, Canadian public opinion, assuming a safe and effective vaccine, is sitting in the low 60% for acceptability of COVID-19 vaccines. In Indigenous Canadians, of the most recent survey, which I think was in August or September, it was in the low 40% range. So there is a gap. then I guess maybe Caroline, I could hand it over if there are discussions that you've been having already, or if you have any thoughts about that, about how to address that gap, and if there are conversations already about creating safe immunization, like culturally safe spaces and things to that effect.
Yeah, and I think that one of the things that we need to really look at is a social determinants perspective on it. And I think even just to talk about our current learning. So for example, when we did testing and assessment centers, the biggest realization was not that, we all of a sudden could get testing and assessment centers in our communities. It was getting people comfortable enough to actually go in for testing and assessment to begin with. And a lot of that comes from historical, those colonial aspects that we had before with regards to things that would have happened in the residential school experience, and a lot of those past historical traumas tied to people feeling comfortable to go into that setting for care. So I think that, one of the things we even found out is saying to people, well, no, I live in a home that has 12 individuals, 4 families living in one home. I test positive. I have nowhere I can go. So it wasn't just beyond, here you go, the government plopped the test to us. No, we need to think of these strategies to say, well, I'm not going to go, because what happens if one of us tests positive? Where do we go? We have no money to actually have anybody self-isolate. And I think that that's where we needed to really band together as the social and health aspect of care to say, how do we do this? This cannot be done in isolation. It has to be done as a cohesive strategy.
Great, thanks. So Sagan did write back clarifying that he or she meant vaccination. So thank you for that response. Okay, so any other questions or comments from the audience? Well, we can wrap up. We're just approaching 5 o'clock. So I just wanted to thank all of our speakers, Matthew, Maxwell, and Caroline, for your excellent presentations today and for answering our questions. And to Lori Bolchuk from the JCB and Liz from the Joint Center for Vaccine Preventable Diseases for doing all the behind the scenes organizing of this webinar. So thank you to the audience for your attention, and please stay safe. And we look forward to seeing the report from NACI next week. Okay, thank you very much. Take care and bye now.